Welcome back. In this second lecture, we address international health and healthcare systems and/or experiences. How can we talk about the differences and similarities in health and healthcare experiences internationally? So here the focus is on comparison between countries. It would be easy if there was a single measure to determine the quality of health and healthcare in a given country, but there simply isn't. So without these standardized or common points of measurement, we make use of a set of indicators that reflect aspects of health on which comparisons are then made. These indicators include factors such as infant mortality rates and life expectancy, variables that you are by now familiar with. Alternatively, we can look at measures that relate to service access or experiences of service access and healthcare costs. We're going to look at the complexities or challenges of international comparison by way of 4 key challenges or key issues. The first pertains to data quality. We need consistent definitions of what is measured in order for comparisons to be made. But as evident from our discussion on culture, different countries may have different ways of defining what is healthy and what is ill, something that is often considered in the field of mental health and mental health research. Without a common or agreed upon definition, comparisons just can't be made. Let's look at a specific example, infant mortality rates. This is often considered reflective of a country's socioeconomic position, as well as the effectiveness of the healthcare system. Generally speaking, infant mortality is defined as the number of deaths under 1 year of age in every 1,000 live births. So here we have a definition. But what counts as a live birth? Well, in the US, in Canada, in Japan, and here in Australia, very premature babies count as live births. But in other countries, they set a minimum. So for instance, a birth is only considered live in France, in the Czech Republic, if the baby is a minimum of 22 weeks or 500 grams. So here, even with a broad stroke definition, there is variation in this measure, which makes comparison across countries difficult or fraught. As a further example of the challenges inherent to the quality of data, let's look at self-assessed health. There is no agreed upon Likert scale, so scales that appear as on screen here, for how to measure self-assessed health or self-assessed well-being. And it makes a huge difference what kind of anchor points you're using. Let's have a look at these 2 examples. So in this first example, the mid-value is fair. In this second example, the mid-value is good. So here we already see the positive framing or positive valence of this second scale. Beyond issues regarding data quality, there are challenges inherent to the collection of data. As suggested on this screen, data collection relies upon a country having an administrative system or administrative protocols. But some countries, for instance, do not have a mandatory death registration. Or, as another example, sometimes body height and weight statistics are self-reported by way of a national survey, which creates space for positive or social desirability bias. A question for you to reflect upon here is as follows. Is it appropriate to compare data collected from different collection techniques? So here we're really getting you to think and or question the limitations of international health data and comparisons between countries. Another complexity pertains to issues of sampling. As we know, the people you sample must be representative of the population to which you are seeking to generalize or speak for. So, for instance, if there's no death registration, perhaps a way to ascertain rates of death or causes of death is by way of sampling. But when we do sample, when we ask people directly, we need to ensure that who we sample are indeed representative of, in this case, the diversity of an entire country. The final challenge to making statements of comparison across or between countries is quite an intuitive one. Are we comparing data from the same time period? Look at where we are now. Is the data on mental health pertaining to a pre-COVID era or a COVID-19 era? This will make a huge difference to what we're observing and the validity of the comparisons that we see made. So the key take-home message is really this. Are countries sufficiently similar to compare? Are the practices of data collection, the quality of data, the sample population, and the time period convergent? These are the kinds of questions you need to ask when analysing international data on health and health systems across and between countries. This concludes our second lecture on healthcare for week 9. I look forward to seeing you in class.